as well. Thank you so much. Thank you so much for giving us the opportunity or chance to present our project to you.
Of
Nice
course.
meeting you. Thank you so
Too.
much.
Yeah, and let me call the head nurse, Miss Ivy. Can I call Miss Ivy? Unmute yourself, Ate Ivy. Unmute yourself, Ate Ivy.
Hello. Hi, good afternoon there, Ms Colleen. I am Ivy Benitez. I am the head nurse of 26 ICU. And we welcome you here in Saudi Arabia too.
Thank you,
Nice
Ate
to meet you.
Ivy. Yeah, I would like also to welcome Miss
Welcome.
Femi, one of the EBP member. Femi, can you unmute yourself? Yeah, she was the one who was with Magnet. We had our Magnet accreditation last first week of December, and she was the one who presented this evidence-based practice, Miss Femi.
I don't know how to. Um, hello. Ay. Okay. Um.
Okay, let me check first with Myra. Myra is the nurse clinician. She can introduce herself.
Yes, good evening, Ms Colleen. Welcome to Saudi Arabia.
Ano ba?
Fortunately, I'm on my way home. I am driving. I will follow. Good evening.
Okay,
Nice to
and
meet you.
of course, the evidence-based practice leader, Miss Mary Rose.
Hello, good evening. I am Mary Rose Ato, the leader.
Paano ba? Paano ba?
Welcome
Yeah.
to Saudi Arabia,
Nice to
Miss
meet you.
And Miss Julia.
Hi, good evening. My name is Julian Cordova. I'm also one of the members of this EBP project in collaboration with Ward 27. Nice to meet you, Ms. Colleen.
Nice to meet you.
Yeah, and we have also Valerie.
Hello, Miss Colleen. Good evening. I'm the secretary of the EBP project of 26 and 27. I'm Valerie Alino.
Nice to meet you.
Okay, and
Nice to meet you.
Miss Andrea.
Hello, good evening, everyone, and good afternoon to Ms. Colleen. Welcome to Saudi Arabia. I'm Andrea Broso, the nurse manager of Pediatric Cardiology Ward 27. Thank you. Nice meeting you, Ms. Colleen.
Nice meeting you too.
Yeah, so just to give you a background of the hospital, Miss Colleen, we are cardiology center.
Okay.
So they are members of two wards, which include, they call it as 26 and 27. So we have two head nurses here, and they are the one who is doing the medivac. They call them as medivac, but that is actually inter-hospital ambulance transfer. So to give you an
Okay.
idea and to give you the challenges of our hospital, Diane will introduce to you the evidence-based practice, and we want to know what you can share with us, your best practice there in United States. Yeah,
Absolutely.
yeah.
So nice to meet all you guys. Just to give you a little background and introduce myself too. I'm Colleen Butler. I'm the Nursing Professional Development Specialist for the our neonatal pediatric transport team here at Advocate Children's, which is right outside of Chicago, Illinois. I've been doing this quite some time, so my background is primarily PICU, but we do neo and peds transport here, and I've been with the team for upwards of 17 years. So I'm excited to hear about your evidence-based project, as well as offer anything I can to answer any of your questions or help in any way.
Yeah. Okay, thank you. So I'll give the floor to Ms. Diane.
Good evening again, everyone. So tonight, I'm going to give you a quick presentation of our ongoing evidence-based project, which is entitled Inter-Hospital Ambulance Transfer Preparedness Program for Pediatric Cardiac Nurses in PSCC. So can you see the screen that I'm sharing, or?
Yeah.
All right. So to begin with, as Dr. Mann mentioned a while ago, we call our inter-hospital ambulance transfer as Medivac. So actually, we don't have a clear guideline or protocol in the hospital that we follow prior conducting a Medivac, or let's say fetching a patient from the airport, as well as transferring patient to other hospitals in Saudi Arabia. So we conducted or decided to proceed with this project because we have triggering issues such as the following. So number one, there is a lack of readiness program for nurses during inter-hospital ambulance transfer. And anxiety of inexperienced nurses are verbalized during transport, especially for non-intubated patients. Because, Ms. Colleen, in this hospital, especially in pediatrics, when you pass the pediatric advanced life support and the sedation course, that will be the time that you will be asked to fetch a patient in the airport. Otherwise, no guideline or protocol to follow. So these are the things that we identified as issues. There are no prepared list of things to bring during transport. There is no training on portable incubator, as well as no orientation regarding the ambulance setup, because our ambulance department is just a shared service between Prince Sultan Cardiac Center and Prince Sultan Military Medical City. And there is unclear guideline on admission through the emergency department as well. So overall, no protocol or guideline. So we are aiming to develop a protocol or guideline. That's why we are conducting this project. So as you can see, the aim of this is to increase nurses' competency in managing patient care during ambulance inter-hospital transfers through an ambulance preparedness program, thus promoting patient and nurse safety as well. So for this one, we had our launching last year, October 30, 2024, and it was participated by the different units, and the EMS department was also invited that time. And we also collaborated with the life support education team to have a quick ambulance MAC code, which was held on April 17. And actually, this ambulance MAC code went well, and we are still hoping to conduct 2 or more sessions with them, because actually we want to include more of our staff in the training. Part of our awareness program for this one is conducting in services and also posting, not posting, actually, we have our education boards wherein all the evidence-based projects and researches are posted. So this is also mentioned during unit meetings to create awareness about this project to all the staff. What else? Implementation strategies include also building knowledge and commitment. So collaboration and coordination with the EMS, which I have mentioned a while ago. And we are currently working on gathering information from the last 2 years from the cases and information about the patients that we admitted from other hospitals in Saudi Arabia. And to promote action and adoption, still, we want to collaborate continuously with the life support education and the emergency medical services, and to conduct post-survey. That we did not reach yet. However, we are working on it. And desired outcomes for this is to increase the nurses' knowledge and assess attitude and behavior in managing patient care during ambulance inter-hospital transfer. And to share with you is an actual video of how we are fetching patients from the airport. And let us see how we are conducting Medivac in Princeton Cardiac Center. Can you hear the sound of the video? Is it clear?
I cannot.
It's okay, Diane. Maybe you can just narrate what's happening.
I'll just pause for a while just for you to see what's happening. Actually, this is taking endorsement from the Medivac nurse. This is the Medivac nurse. Actually, they just assign her also to endorse to our nurse from PSCC. So whatever she wants to endorse, she will endorse. There is no clear guideline on how to endorse as well from their side. So we will just take whatever we want to take and we will just ask questions from her.
Where this Medivac nurse, where do they come from? Like, where are they? Are they part of another hospital
They
or
other hospitals in Saudi Arabia.
in Saudi Arabia? Okay.
This is the airport.
Okay.
And this is the Medivac nurse with the doctor bringing the patient to our ambulance. So now they are giving the patient to the nurse in Princeton Cardiac Center, a ventilated patient with all the contractions.
I think I'm a little frozen on this end. I'm still seeing inside the fixed wing getting endorsed on the video. Yeah, it's still
Oh,
showing
they
it like
are
16 seconds. Yeah.
You can play it now, probably, Diane.
dali lang. Naku, 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 naku.
Okay, there we go. I can see it now.
Sorry for the inconvenience, Ms. Colleen.
No, you're
I think
fine. You're fine.
my internet is a bit slow.
No, you're fine.
Sorry. I'll just repeat.
Yeah. Can you repeat it a little while and show to Miss Colleen that we are bringing the baby out from the incubator.
Yeah.
You know, Saudi Arabia reaches 52 degrees during summer. So there is a sudden change of environment because the issue there is that they cannot bring out the portable incubator from the aircraft.
Gotcha. Yeah.
So, yeah, can you see this one?
Yep. So you guys carry them out.
and pumping the baby.
Gotcha. Okay. Interesting. Do you guys experience a lot of temperature instability from that transfer?
Yeah, for sure. Because that will start. I mean, they notice that the baby will start to agitate because
Yeah,
of sudden, yeah, even
just
the
everything.
sudden change of temperature, their eyes,
Mm-hmm.
everything will change. You
Mm-hmm.
know.
Can I ask, what is the typical age of your babies that you're doing these transports?
Ms Colleen, we cater 0 to 14 years of age of patients in
Okay.
pediatric cardiology ICU and pediatric cardiology ward.
Okay. Is your main, like with this right here, I know you had said the temperature and stability. Are your babies more neos, like preemies, or do you kind of range variety of ages?
For this
It's
one,
actually a variety of ages.
Okay.
Yeah, like days old, 2 months, or um, up to 14 years old.
And of the, like 0, 1 day olds, are those typically term babies or are they preterm?
We do have as well preterm babies,
Okay.
but very rarely.
Rarely. Okay.
Yeah.
Okay. So most of the babies that you're moving, would it be fair to say, have decent temperature regulation or?
Sorry, Miss Colleen, come again about the temperature.
So because I think you said that you don't do too many premature babies, most of them are term. Do you
Yeah.
find that they're already kind of temperature stable, if you will, for the most part, don't have a lot of instability with their temperature?
Yeah, but of course, we still need to regulate that one inside the craft, as well
Right.
as the portable ventilator that we are bringing. The
Okay.
incubator, yeah.
Okay. Okay.
so now this is in transit going to Prince Sultan Cardiac Center from the airport,
Okay.
and that's it.
Okay. It's interesting to see other people's perspectives and how they, although kind of the same work environment as far as the close quarters and everything else.
Now, what we want to ask from you is that the best practice that we should improve in our current practice. Currently, we were not able to get any literature of regarding the practice of there is no sudden change of temperature, and how do you bring down the baby or transport the baby from the aircraft? Is it something that the incubator from the aircraft should be bring it down until to the ambulance? What's your practice?
So we don't do a lot of fixed wing. We rarely do them. We're mostly ground or rotor wing. And for all of those, we keep the baby in the same isolate or incubator. So we don't take them out and put them into another one for the ground transport. We have one that is flight regulated to use for flight, and then it's able to be offloaded off of the helicopter or fixed wing, and they stay in and then they can go into the ground ambulance in that too. So we don't take them in and out. What I would say, it is very hard to find literature on transport, especially when it comes to neonates and pediatrics, right? We've found that with anything, we kind of have to see some adult stuff and kind of go from there. I think it's hard to say. I guess I should say, do you have the capability to, sorry, I'm trying to frame my thoughts as I'm thinking through this. Is your biggest challenge the temperature changes, or just in general the lack of the babies tolerating being moved from one to the other?
One of the challenges is that we want that the baby, when it is transported, there is no change of temperature. Mean to say, if it's in the incubator, it must be transferred inside of the ambulance, because what we have right now, currently, our hospital portable incubator is big, heavy, and it
Mm-hmm.
cannot be lifted until it reaches to the entrance of the aircraft, and it cannot even enter to the aircraft door.
Right.
So the thing is that what they are doing is that they are bringing out the baby out from the incubator inside of the aircraft and bringing it down.
Yeah.
Then transfer to the ambulance portable incubator. So is this the best practice that we are doing? Or I don't think so.
I would probably say, unfortunately, no. However, I think given you're kind of limited, right? You don't have the capability to get the incubator out of the or out of the fixed wing, or yours into the fixed wing, right? I would think that maybe the option is to unload yours from the ambulance and bring it as close to the aircraft as you can and load there. I don't know that that's, I think best practice would be if you could have the incubator being able to unload off the aircraft. You know, that would be the best practice. I do know that our fixed wings that we use are able to do that. I'm not well versed in what that looks like as far as the mechanical part of it as well. So it does pose a challenge. Do you see a lot of adverse effects of that transfer in the current process?
What they notice is the baby start to have agitation. Number
Yeah.
one is the sound. Number two
Yeah.
is the sight of the baby, because from portable incubator, and then there is a sun out
Yeah.
there.
Do you have any eye protection
That's the one that we are looking for our intervention, is to purchase that one, like eye shield protector. And we are looking also for ear pod that has a decibel noise cancellation.
Yeah, so
higher decibel noise cancellation, but still the sudden temperature change, this is something that we need to adjust to the baby.
Yeah, I think that's a good start with the eye and the ear protection. I can send you some information what we use. We currently use a device called the Transportal, which is made by International Biomed, who does our isolettes or our incubators. So I can send you that, and it comes with ear protection and eye protection as well. And then we also use a device called mini muffs as well. That's just an additional thing we can use for our ear protection. Currently, a side note, we are looking at a lot of those things as well, as far as like all those what we're calling transport environmental effects on these babies. We just finished a big research study on what specific to transports could potentially contribute to intraventricular hemorrhage rates. So we've done a lot of looking at some of these different devices and such. And as you know, especially these small babies, they don't want to be manipulated and touched and moved around a whole lot. So I would maybe also consider for these little ones, looking at sedation when moving. That might help with some of the agitation. Like I said, I can send you some information on the different devices that we have for securement, and that might help with moving them as well, because it kind of helps contain the baby a little bit. Let me see if I can pull it up on my computer and I can share my screen. Give me 2 seconds. Do you mind if I share my screen?
Go ahead and make you already a
Sure.
co-host.
Let me see if I can figure out how to do this being on Zoom. I typically use Teams, so. Oh, share, there we go. Can you see my screen? Oh, wait, hold on. Oh, maybe not. Can you see it?
Yes.
Yeah, we can see it.
Okay.
We can
Okay.
see it.
So
Yes,
this is
yes,
one
we
of
can.
this is one of the devices that we use. We use it for our babies who are less than 31 weeks gestational age and less than 1,500 grams. They do make it for larger babies as well, and a lot of it is, it's this wedge positioning. It has the ear muffs, it has the eye protection, and then it has, what we call containment borders, just to kind of help with the containment of the baby, which does help with some of the comfort and agitation. This has also been marketed as helpful to reduce vibration and noise when kind of all the pieces are used together. So this is one thing that we use on our babies. It is a little on the pricey side, which is why we only use it on our less than 1,500 grams and our less than 31-week babies. But that's the one thing that we do use. But I would also kind of to go back a little bit to your evidence-based project too. I'm happy to share anything that you may need as far as just like training, in general, because it sounds like you guys are a newer program too. And we've been around for almost 30 years. And we have, been there, with the newness and trying to figure things out and trying to figure out what best practices are. And it's hard in the transport world because there's not a lot of literature to support a lot of this stuff because it's all bedside, right? So we try to adapt some of these things too. So, but I would definitely start with, your eye protection, your ear protection. I would look at this transportal. I can send you some links of, information. I would look at maybe some sedation protocols as far as maybe, if you can't keep them in the same incubator from moving from aircraft to ambulance, to give some sedation as well. Temperature wise, it's going to be a little bit of a harder one, I think, because you're out in the environment and that makes it real difficult. We deal with more extremes of cold versus heat here. We do get heat, don't get me wrong, but not like you guys do. So we're typically more worried about the cold end versus the hot end. So we more deal with keeping our babies warm than, I guess, not, overheating them. But I'm happy to share those resources. And then again, I think what you guys have done as far as you're starting off with your program looks great. It's a lot of work. It takes a lot to figure this all out. Are you guys staffed? Are you part of your staffing unit and then you get pulled to go to the transport?
Exactly, that's what's happening. They are from the unit, and once they receive for admission, and there is a dedicated nurse assigned to that day, and that nurse will go directly to with the ambulance.
Okay. Yeah. So we are a little different. We do not staff in the unit. We're our own department, and we go out with a nurse and a respiratory therapist, which is an invaluable part to our team, those respiratory therapists, because they manage the vent and the airway and everything else, which is very helpful from a nursing
So
perspective.
you mean to say your services is exclusive for transport?
Mm-hmm.
So you're not anymore working in the bedside? Correct.
Our team, when we started a long time ago, that's how we started too, like you guys are, where we pull from the units. We have evolved to and what we call a freestanding team, where we're just transport. That's all we do. So we've evolved through over time with that too. So I think that's the kind of starting point for a lot of teams, is to be part of a unit. But in addition to some of this stuff, I'm happy to, share anything
When
that you
did you
may.
decided to have a separate unit? What
Oh,
was the indicators for that?
I think volumes, how many, the need, and the fact that you're getting pulled out of the unit so much that that was a necessary thing. I think I'm trying to remember how long we were, since we were pulled. I think it's been most of the time, I'm going to say at least maybe the first year or two, they were just pulled from the unit. And then after that, we've been a freestanding independent team. And again, it's just volumes. Like we do so far this year, we've done about 105 neonates alone. And then that's not including our pediatric patients and everything else. So, and we run a full team on days, a PM team, like a late afternoon team, and then a night team. So we have multiple teams that run.
I think we can share with you also our statistics. Am I right, Diane? We have the statistics of how many Medivac you conducted.
Yes, I can share that with you. Just for a while.
And your team, Ms Colleen, consists of all nurses and respiratory therapists?
Correct.
Okay. This is something that we have to revisit our statistics and recommend to have a separate unit. Because this is one of the anxiety of the nurses, that they're being pulled out.
It's hard.
And it's very consistent. And it's very consistent. And don't you know that they don't have NRP? Meaning to say, they don't have training in NRP, but they are catering neonatal.
Okay. I would highly recommend that your team do NRP. I think, and then there's also the stable. I don't know if you guys are familiar with stable class, and then there's a cardiac stable class that we all have to take as well. It just kind of provides some extra. Stable is basically stabilization of the newborn for transport, and then cardiac is the cardiac component of that as well. I would also recommend looking at the American Academy of Pediatrics has an air and ground transport guide for neonatal and pediatric transports. That's a lot of kind of great information for kind of hitting the ground running and getting a team started and what is needed. It's a lot of trial and error, and it's a lot of changes, and there's a lot of different, like we go through changes a lot as far as realizing this is the equipment we carried 10 years ago, and we've tried to streamline it down as we've gone, and then we end up adding new stuff. So it's an ever evolving thing.
Do you have also, Ms. Colleen, a how do you call this one, a checklist or a documentation of inter-hospital transfer? Because currently, right now, we don't have any documentation at all. They just write it on the piece of paper.
Oh, yes, we have we call it a record. Like we basically is a paper charting of, vital signs and all the information, assessment pieces. Yes, we do have something that we use.
I would love if you can share it with me, and
absolutely.
I can share it with them. Yeah, go ahead, Miss Diane. Maybe we can share, and if it's recommended already to have a separate unit.
Actually, Ms Colleen, this is the summary of inter-hospital ambulance transfer from year 2022 until 2024. So for this graph, it represents 26 ICU inter-hospital ambulance transfer from the last previous years. So the statistics show that there were 141 total inter-hospital ambulance transfers for 3 consecutive years that involved 26 ICU, significant indication of potential shift in patient care needs. And the nurses are not trained in the ambulance setting before actual engagement. Actually, as I have mentioned a while ago, there is no proper orientation from the ambulance set up. We just go there and we bring our things like transport boxes, which includes emergency medications, equipment, airway, bag valve mask device. And if the patient is intubated, we will be with the doctors and the RTs, including EMT and the driver. However, if the patient is non-vented, So it will be the nurse only together with the driver and the EMT. So this
Okay.
is for 26 ICU, 141 total inter-hospital ambulance transfer for the last 3 years. For uh, pediatric cardiology ward 27, for the last 3 years, we have total of 18 admitted patients for the last 3 years. Correspondingly, nurses involved in inter-hospital ambulance transfers have similar concerns about the need for ambulance preparedness training. So our training only is the pediatric advanced life support and with the sedation course alone, nothing else. And we are just bringing a paper for Medivac admission, which
Can you
we asked the
can you
Medivac
can you
nurse.
next can you play next slide? That I think that
This
is on the next slide. 26 to 7. Next slide.
this is 27. Is it
No, but it's
moving?
showing to, no, it's not moving to us.
Right. Just
Okay.
this is ward 27. 18 admitted patients for the last 3 years. Yep.
And the other one was a different ward, so they're broken down between different. Okay.
The other one, Ms Colleen, is pediatric cardiology ICU. And
Okay.
pediatric cardiology ward is the step-down unit of that unit.
Gotcha.
We are just, neighbors. And
Okay.
compared to us ward, they have more patients admitted via Medivac.
Gotcha. Okay. Yeah, I would definitely say I will send you what our record looks like. It's pretty extensive. I can also share like what our training, our orientation, you have to have at least 3 years of critical care experience to be on the team, like ICU experience. Our orientation training looks typically anywhere from about 3 to 5 months that we train before you are able to do transport by yourself. And I can send you kind of the breakdown of what that looks like too. We have a lot of classes, additional classes that our nurses and our respiratory therapists have to attend, as well as they are also trained in intubation as well, because we do not take a physician with us ever. Except when we do our ECMO transports. We do ECMO transport and then we'll take a physician, a cardiac surgeon. So that's it. But yeah, I'm happy to share and discuss anything to help you guys along too. And I will definitely send you some of these resources for those babies coming in and out of the incubators, because that does pose a challenge 100%. And I think some of these devices might be helpful to you.
I appreciate your help, Ms. Colleen, because
Yeah.
as much as we want to improve our practice, this is for nurses' confidence to handle the baby for patient
100%.
safety. Yeah.
Yeah.
Because currently, right now, how they rotate the nurses, even new nurses are engaged in transporting. So as you have mentioned, there should be a training and they must be at least 3 years experience.
Yeah, it's
So,
rough. It's a different environment than being at the bedside. So I think that it's sometimes even 3 years is hard, to be honest with you, but it's definitely challenging. But I think the confidence and the success of your nurses is gonna happen the more you can support them and give them that education.
yes. And
Yeah.
we're very thankful
Resource.
for this meeting, actually.
Yeah, no,
Because
to help anyway.
yeah, because we really trying our best to look into literature, but this is our challenge. We cannot find, as you have mentioned, there are very list published articles regarding transporting, and we have found one coming from Spain, This is a pediatric society from Spain,
Okay.
but not enough as what we are looking for.
I
And
hear
good
you.
to know that you are there. At least we can collaborate with each other. Most especially, what we're looking for is that the training and what are the requirements for a nurse to be part of this transport system. And at the same time, also the challenge that we are encountering is how to transport the baby from the aircraft to the offloading this baby.
Yeah,
So
that's for sure a challenge, and I agree. I don't think it's best practice to take the baby out down the stairs and load them back in. I think that you could definitely mitigate some of those things by using these devices a little bit. I think that eye protection, the ear protection, the transportal, or there's some other devices I can send you information on that, we don't use, but I've seen before. So it's just a matter of what works well for you guys.
yeah.
That would help. Again, I think the best thing would be to stay in the same incubator, but if that's not an option, I think doing some of these other things would be helpful as well.
Okay. Thank you
You know,
so
we
much.
also have standing protocols for our transports, so that's helpful too, that we already have kind of already spelled out ways that we can give sedation and other meds and stuff like that.
Okay. Any other question from the team? Any other question from the team? Can I
I
hear
don't have actually, but I want to thank Ms. Colleen for this opportunity. And hopefully we can address the issues that we are facing in transporting the patient from the aircraft to the ambulance and then to our hospital. Thank you, Ms. Colleen.
Of course, thank you. It was so nice to meet all of you guys. And I will send you a bunch of this information as well. And then again, I'm always here if you have any questions or need anything to talk about or discuss and help with
thank
some
you
of
so much.
your challenges. Of course.
Thank you, Ms. Colleen, for this
Thank you.
opportunity.
Thank you. Hey, Andrea,
Thank
do you
you.
have any
Your
other question?
practice project is amazing.
Oh.
That's really good work. Thank you.
Yeah.
I have no other questions, but thank you, Ms. Colleen, for accommodating us to this meeting.
Of course. Thank you.
Okay, so I think this will conclude our night and your afternoon because you still have work tomorrow. So, Ms. Colleen, we will keep in touch with you, and
Absolutely.
we're looking forward if you can share the informations that we needed, and we'll work on our part. And what we heard from you is sufficient enough to have our practice really need to be changed. Most especially the requirement of the nurses.
It's always a work in progress, right?
Yeah. Okay,
right,
so
well, thank you so much. It was good to meet you.
Yeah, so
Thank you so much.
have a good day, Ms. Colleen.
You too.
Okay,
Thank
bye-bye,
you.
bye-bye.
Bye.
Bye, everybody.
Bye.
Thank you so much for
Thank
the
you.
night.
Bye. Thank you so much,
Thank you,
everyone.
Dr. Man.
Yeah, thank you so much. Thank you.